First of all, I would like to express my deep gratitude and thanks for the organizing committee for this excellent organization of this conference. I would like to thank you all for the attendance. Thank you very much. I'm really honored to be part of this. My talk today, Hepatocellular Carcinoma, Post-Therapy Assessment, MRI Updates. The objectives of the talk: to highlight treatment options of hepatocellular carcinoma, to discuss emerging MRI techniques, to describe the post-therapy MRI appearance of HCC, to highlight the impact of new MRI imaging techniques in post-therapy assessment of hepatocellular carcinoma. Hepatocellular carcinoma is the major worldwide health concern. It is the third leading cause of overall cancer-related mortality. HCC has a rising incidence in Egypt, mostly due to high prevalence of viral hepatitis. HCC has a poor prognosis unless properly managed. HCC treatment options based on the Barcelona Clinic Liver Cancer Staging System is for the early stage surgical, and the cure is 100%. The surgical treatment is liver transplantation or segmental hepatectomy. Endovascular treatment, as mentioned by Dr. Usama, transarterial chemoembolization or transarterial radioembolization using yttrium-90. Percutaneous treatment like thermal radiofrequency, microwave laser ablation, or chemical like ethanol injection. In advanced disease, they use systemic treatment. They use anti-angiogenic novel agents such as sorafenib. Imaging follow-up plays a crucial role in evaluating treatment effectiveness to take important management decisions. CT is used to follow up of the patients 1, 3, and 6 months after treatment, and every 6 months afterwards. But we have certain diagnostic problems with the CT. Number one, the beam hardening artifact and the high attenuation of the lipidol after transarterial chemoembolization, which makes the assessment of the underlying enhancing residual tumor tissue very difficult. Number two, the persistent elevation of alpha-fetoprotein with negative and inconclusive CT. Number three, after systemic angiogenic therapy and radioembolization, the assessment of treatment response is based mainly on the change in tumor size according to the modified response evaluation criteria in solid tumors, where the tumor should regress by more than 30% to say that there is partial response to therapy. Therefore, the challenge for a reliable response biomarker holds crucial to rapidly alter treatment strategy. The state-of-the-art functional MRI techniques will help to reach this issue, like diffusion-weighted MRI and dynamic contrast-enhanced MRI perfusion. These new emerging techniques provide not only anatomic, but also functional imaging at molecular level. Diffusion-weighted MRI, no contrast media administration is required. The water molecule, it gives information about the water molecule's mobility, tissue cellularity, and integrity of the cell membranes. As we see here, when there is high cellular packing and intact cell membrane, the motion of the water molecules is markedly restricted. On the other hand, when there is low cellular packing and loss of cell membrane integrity, the motion of water molecules is markedly facilitated. Therefore, tumors with high cellular packing will show diffusion restriction and appear hyper-intense on the diffusion-weighted imaging. Diffusion is quantified by the apparent diffusion coefficient. Its unit is millimeters per second. And quantitative parametric map, like this here, the ADC map, which is based on the B-values that we applied, 0, 200, and 800. To confirm that the lesion has two restricted diffusion diffusion, one should always compare the diffusion-weighted image with the apparent diffusion coefficient image to avoid the so-called T2 shine-through. Therefore, the lesion, when it appears hyperintense on the diffusion-weighted image, we should see the apparent diffusion coefficient map to be sure that it has a low signal intensity on the apparent diffusion ATC map. Then we apply a region of interest to the low signal intensity region, and the ATC value is automatically generated. This ATC value can be used as an early biomarker of HCC response to therapy. And the increase in ATC was described after 2 weeks, only 2 weeks of therapy before size changes occurred. One of the drawbacks of diffusion-weighted image is lack of anatomical details, as we see here. Therefore, we can combine the functional diffusion-weighted image with the anatomical T2-weighted image to have a fused image that gives us functional and anatomical information like that of PET-CT. Dynamic contrast enhanced MRI perfusion. This new technique was recently applied at our MRI unit at Ain Shams University. It quantifies the pharmacokinetics of injected contrast media with 5 to 7 consecutive rapid image acquisitions before, during, and after contrast media administration. We use a T1-weighted 3D gradient echo-fat suppressed sequence. This technique is used to characterize tumor microcirculation and angiogenesis non-invasively. Semi-quantitative time intensity curves, quantitative parameters, and color-coded maps are generated. The quantitative parameters are relative enhancement percent, percentage of maximum enhancement, percentage of maximum relative enhancement, time to peak, wash-in and wash-out rates. These quantitative parameters can be used as biomarkers to quantify tumor angiogenesis and to follow up and assess the response of treatment. This is our MR perfusion that is applied at our MRI unit. We apply a region of interest to the aorta at the level of the celiac trunk. Another region of interest will be applied to the portal vein. The third region of interest will be applied to the liver, away from the normal liver, away from the hepatic focal lesion. The fourth region of interest will be applied to the hepatic focal lesion. And time intensity curves are generated. As we see here, the time intensity curve of the aorta shows rapid wash-in, rapid wash-out, and short time to peak. On the contrary, the time intensity curve of the normal hepatic tissue shows slow wash-in, slow wash-out, and long time to peak period. Also, all the quantitative measures are generated here for the 4 regions of interest and can be compared together. Also, color-coded maps can be generated for each quantitative measure. MRI appearance of well-treated hepatocellular carcinoma. After transarterial chemoembolization and radiofrequency ablation, coagulative necrosis and hemorrhagic products can be seen. The coagulative necrosis appears hypo-intense on T2, hyper-intense on T1, and more hyper-intense on T1 fat-SAT image. On the diffusion restriction, there will be no evidence of diffusion restriction apart from that sometimes microhemorrhage may be present and produce diffusion restriction. The other type of necrosis that can be seen is liquefactive necrosis, and liquefactive necrosis gives the signal intensity of fluid. As we see here in this rim, it will appear low on T1 and high on T2. The problem is that post-therapy T1 high signal due to coagulative necrosis or microhemorrhage will make the detection of enhancement within such lesions very challenging on MRI. How to solve this problem? we do dynamic subtraction MRI technique. We subtract the pre-contrast high signal intensity T1 image from the post-contrast image. And we see if there is residual high signal intensity, that means that there is residual, there is enhancement, true enhancement. Residual tumor mimics, we should take care of this in order not to misdiagnose residual tumor mimics with residual tumor. This is like inflammatory reaction or fibrosis surrounding the treated lesion. This appears as hyper-intense rim around the lesion on T2 weighted image. It will show enhancement, and that will persist to the portovenous phase. It also may show diffusion restriction. Word of caution that must be said here, that diffusion-weighted images should always be interpreted in conjunction with the T1 weighted images to avoid the confusing effect of hemorrhage on diffusion-weighted and ADC. As we see here, on the diffusion-weighted image, we can see diffusion restriction at the periphery and the center of the lesion. But when we correlate it with the T1 weighted image, we see that it is due to hemorrhagic component. Another tumor mimicker is arteriovenous shunting or transient hepatic intensity difference due to portal vein thrombosis that may be induced during the radio frequency ablation procedure. This arteriovenous shunting and transient hepatic intensity difference will appear as a wedge with sharp edges. It will show enhancement in the arterial phase that will persist in the portovenous phase or become isointense in the portovenous phase. On the other hand, the residual or recurrent hepatocellular carcinoma, as it appears here, it will have a hyper-intense signal on T2. It will show focal and irregular peripheral enhancement in the arterial phase, but the most important point also is that it will show washout in the portovenous phase. And we will see diffusion restriction and low ADC value in the recurrent or residual hepatocellular carcinoma. MRI offers a higher sensitivity than CT in detecting residual tumors. This one of our patients, 70-year-old male, underwent transarterial chemoembolization and presented with elevated alpha-fetoprotein. As we see here, at the center of the lesion, there is coagulative necrosis with high signal at T1, low signal at T2. We notice that there is peripheral nodular thickening at the periphery of the lesion that exhibited low signal on T1, high signal on T2, and showed diffusion restriction. We did our perfusion MR imaging technique, and we applied a region of interest at the center of the lesion. The time intensity curve was dead flat, denoting that the center of the lesion was necrotic necrosis. We applied another region of interest at the suspected area of residual tumor, and we see that the time intensity curve showed rapid wash in, rapid wash out, and the time to peak was much more shorter than the normal time intensity curve of the adjacent normal liver here in blue. This confirms that the periphery of the lesion was a residual tumor. Another patient, 56-year-old male, underwent transarterial chemoembolization, presented with persistent elevation of the alpha-fetoprotein and negative CT study. As we see here, in the CT pre and post contrast, there is concentration of the lipidol that has a very high density, and which makes the assessment of underlying enhancement of a residual tumor very difficult. The arterial phase didn't detect any enhancing hepatic focal lesion. The diffusion-weighted MRI was able to detect a residual nodule that shows diffusion restriction, and it also depicted two de novo hepatomas that showed enhancement in the arterial phase and were not seen at all at the CT study. This confirms that MRI is much more sensitive than CT in detecting residual and de novo hepatomas. Another case, 67-year-old male underwent RF ablation. As we see here, the coagulative necrosis that appears hypointense on T2, hyperintense on T1, with surrounding hemorrhagic capsule. At the arterial phase, we found that there is hyperintensity at the periphery and at the center of the lesion, and we were not sure if there was underlying residual tumor. Therefore, we performed our subtraction technique, and there was no evidence of residual enhancement to account for residual tumor. We did our MR perfusion technique, and we applied a region of interest to the periphery of the lesion, and we found that the time intensity curve was gradually rising, denoting that the periphery was hyperemia, fibrosis, and hemorrhage, and there was no evidence of residual tumor. This case was very well ablated. Another case, 64-year-old patient, underwent transarterial chemoembolization and presented with persistent elevation of the alpha-fetoprotein, and the CT was inconclusive. Again, as we see here, the lipidol has high density. Also, beam hardening artifact at the periphery of the lesion is seen in the pre and post contrast, and the assessment of underlying enhancing residual tissue couldn't be done. At the MRI study, we see that at the posterior aspect, at the anterior aspect of the lesion, we see coagulative necrosis, hypointense on T2 and hyperintense on T1. But anteriorly, we see a nodule that has high signal intensity on T2, low signal intensity on T1, and showed post-contrast enhancement. It also showed diffusion restriction with low ADC value, denoting a residual tumor that was not detected at all by the CT. The ADC value of the residual tumor was very low, 0.68, and that of necrosis was very high, 1.8. Our last case, 57-year-old female, underwent radiofrequency ablation with presented with persistent elevation of the alpha-fetoprotein, and CT was negative for a recurrence. We did our MR perfusion study, and we applied a region of interest at the center of the lesion, and the time intensity curve was dead flat, denoting central necrosis. We applied another region of interest at the periphery of the lesion, and the time intensity curve was gradually rising, denoting hyperemia and fibrosis at the periphery. Another region of interest was applied at a suspected nodule that showed diffusion restriction, and this nodule showed rapid wash in and rapid wash out, denoting that it was a residual nodule, and this shows the high sensitivity of MRI in detecting very small residual lesions. Take-home message: every radiologist and hepatologist should be familiar with the HCC appearance after treatment and should be able to distinguish normal post-treatment changes from residual or recurrent tumor. MRI is superior to CT for post-therapy evaluation of hepatocellular carcinoma. MRI is a problem-solving modality when a discrepancy exists between clinical results and CT findings. State-of-the-art functional MRI provides valuable quantitative imaging biomarkers for monitoring early response to therapy. MR perfusion imaging is promising, however, several challenges remain. Multidisciplinary team, including the hepatologist, diagnostic radiologist, intervention radiologist, oncologist, surgeon, and transplant team is mandatory and offers the best hope for optimal treatment of hepatocellular carcinoma patients. At the end of my talk, I would like to gratefully acknowledge Noha Taha, Assistant Lecturer of Radiology at Ain Shams University, for her dedication and sincere concern about implementing the dynamic contrast enhanced MRI perfusion technique at our MRI unit at Ain Shams University and follow up of the patients. Thank you very much.